The benefits for taking out seizure in a pediatric age are huge. What we want is to operate fast, just to make the period in which people experience seizure, it's very short.
Fellow Homo sapiens, for lots of people with epilepsy, anti-seizure medications just do not control their seizures. And it is more than a tad frustrating, to say the least. Well, this week we are talking to Luca De Palma, a paediatric neurologist and epilepsy surgery specialist from Bambino Gesù Hospital in Rome, who plays a key part in performing pre-surgical evaluations for children with refractory epilepsy. This week being about the role that he plays, the risks and benefits of having epilepsy surgery, and the benefits of having surgery earlier in life. We also have a heap of new terms actually added to the Epilepsy Sparked Glossary as a result of our chat with Luca, so do check those out as well.
I'm Luca De Palma, so I am an almost 40 years old man that is a doctor. From at least 8 years I'm a specialist, doing most epilepsy surgery and involved mainly in neurophysiology. Always dedicated to epilepsy surgery.
Could you tell us quickly how you got into epilepsy and specifically epilepsy surgery? Why is that your focus?
It was just at the beginning of my training. I was just entering in the hospital, and this was the first things that almost I have met about pediatric neurology. And then I fell in love, and from that period it was my focus. And epilepsy surgery came out with my training in France, especially, both in Lyon and Grenoble, and especially thanks to my mentor that were Philippe Kahn and Lorella Minotti that helped me in developing my skills in epilepsy surgery and how to be a doctor and how to be a person that have to cure someone who has some need.
What type of epilepsies do your patients tend to have?
As we are in a pediatric hospital, we have a very, very wide range of epilepsies. There could be, we start from very severe encephalopathy of the first years of life that usually needs a very rapid genetic testing and neuroradiology to understand the disease, and if they are surgically treatable, a very rapid surgery. And but we move on up to the adolescent that are focal epilepsy, like mostly similar to adults one. So they have weekly or daily seizure. They try to have a normal life, but they are quite impaired in trying to have a normal life by the frequency of seizure and by the sudden episode that can have both at school and they cannot have a driving license, so they search for surgery just to try to solve the problem of their life.
So as a neurophysiologist, what part do you play when it comes to the surgery? How do you help the decisions to be made whether a patient should or should not have surgery?
We try to have surgery, we try to have what we call the anatomo-electroclinical correlation. It's a very complicated term to tell that
it's too long.
There should be, to operate someone, we need to be sure that the seizure that are what I want to treat should arise to some specific region in which where we should find a lesion. So these are the perfect anatomo-electroclinical correlation. That means that the shape of the seizure tells us that it comes to a place where I found the abnormalities in the EEG and where I can found the MRI lesion. So when we have all this concordance, so everything is concordant, it means that I can go to surgery. Whenever there are discordances, it means not that you cannot be operated, it means that we need to have more neurophysiology, for example, so high density EEG, and so that are EEG with more electrodes up to 256, or what it was really my most of the training of my life, we need to have intracranial recording. So we need to put the electrodes inside the area that we suspect to be pathological, but in which we cannot find too many arguments. And for that area, we should specifically search with the stereo G the limits of the surgery. And this is the most complicated part to learn, but what can benefit also to the most difficult patients.
And who was involved in making that decision? It's not just yourself, there are multiple people on the team, aren't there?
Usually we have a weekly case discussion in which they're involved clearly the surgeon, the neurologist, and the psychologist, the neuroradiologist, and usually some of us has also expertise in genetics. So usually we are a quite extended team in which lately also the EG technologist and the engineer took part, because there are a lot of feature of the post-processing, both of MRI and of the EG signal, that needs more advanced expertise, especially of myself. So we need the help of engineer and the EG technologist technician to understand better what's going on, and to have the perfect representation of the post-processing of the signal EG and MRI that we have.
And how do you evaluate risks versus potential benefits of surgery?
Okay, so usually the risks are studied with the story that we have. So we have operated more than 300 people with children with epilepsy, so we have quite our experience, and then usually we know about the already reported cases, large series, in which also we took part about reports, which are the common side effects, and so we try to merge the two data, so the personal experience of us that is becoming quite large, and what is already reported. And then the benefits, clearly, the benefits for taking out seizure in a pediatric age are huge, because what we want is to operate fast, just to make the period in which the people experience seizure, it's very short. The children experience seizure very short, so they can restart what it was quite sometimes make more difficult. So about seizure recurrence, especially in adolescent. And for epileptic encephalopathy of small children, just to stop the process of encephalopathy, in which there is the electrical activity per se could be detrimental, and so we try to stop it very, very early. So usually the benefits are large. Clearly there are some indications like low-grade glioma and focal cortical dysplasia, which are quite, especially focal cortical dysplasia type 2, which are quite straightforward and very, very have a lot of benefit from epilepsy surgery. And then there are other indications that are more complicated and should be evaluated case by case, so each time, and the maximum of risk should never be up to 5, maximum 10% of a small transient deficit, and that could be the maximum also for the worst epilepsy. But usually what's the standard is that there is no risk of having any cognitive problem, and maximum 1% or 1% of having some problems during surgery. So this is the maximum risk that usually we speak about to the one who asks for our opinion.
And I guess we have to, consider the risk, yes, of surgery, but also the risk of not having surgery.
Yeah.
Because often, like we're talking about, injuries from seizures, the impact, like you've been saying, on cognitive function or regression even, and the, potential for SUDEP and things like that?
This is what we discuss, especially with parents, because parents, I mean, it's the worst decision for parents, because they have to decide not for themselves, but for their child, and for a child who is not an imminent danger for life. And so for them, it's very complicated, and we have to help. And one of the things that helps is just to think in perspective. So what you want from your child, what you expect, what you hope, especially for your child, and being seizure-free clearly makes the possibilities that you have more than the possibilities if a seizure persists. Then there are the things that could have to be discussed, but it's not to be too direct, because it's always problematic, is that especially life with seizure could be sometimes problematic, especially if you live alone and if you become old. Things get more complicated to be managed, and this is something that they also should know to take their decision.
I can say as a patient, and I've said this in other episodes, and in my specific case, temporal sclerosis, I wish that I had been able to have surgery earlier. I really do. That I hadn't needed to wait till I was in my 30s, which was for multiple reasons. But if that I had to wait that long, but it would have had such, I know from experience and research, such a positive impact on my life, because, the younger that we have these surgeries, the easier it is for you to make new neural connections. And I just think it would have been a much simpler, potentially, life to have had that earlier.
Yeah, what you can do at 18 years old is not what you can do at 30, is not what you can do at 40. So it means that if we can give the possibility of do what they can do at 18, at 25, it's much better than waiting that the decision is obligatory, because the patient asks us, yes, I want, because I cannot stand anymore. So I think that there were a lot of, in the past especially, to wait up to that moment in which it was really the people with epilepsy that says, okay, that's enough, I want. But I think that now we have to discuss earlier and to tell the benefit and the risk, okay, because we cannot hide the risk, but the risk, especially for some indication like multiple sclerosis, now is becoming very few, and the expertise much better. The surgical techniques are really more safe, and having a large center with a high experience and surgeon that are dedicated to that really decrease complication and the possibility of being harmed by the surgery. So it's not more like having a center with one surgery each year in which they cannot be so controlled, the side effect, but having large epilepsy surgery center in which, more or less what you are going through is known.
Thanks so much for joining us today, Luca. Everybody, get ready and look forward to next week's episode, because again, this is a sort of a dual two episodes of a fabulous clinician and researcher. So speak to you next week. Thanks, Luca.
Thank you very much, Torie. Thank you very much.
To learn more about Luca, check him out using the link below, where you can find multiple links to his profiles and his work.